All right, everyone, we'll get started. So thank you to attendees and panelists for gathering here tonight in this shared space where we'll be discussing the policing, surveillance, and criminalization of disabled, mad, and labeled people, both inside and outside of psychiatric institutions. Tonight, we're going to be diving into possibilities of an abolitionist future while imagining non-carceral, disability justice, and restorative justice-centered community care. My name is Ahona Mehdi. My pronouns are she, her, and I'm a member of Disability Justice Network of Ontario's Youth Action Council. And I'm really looking forward to co-facilitating this panel tonight. And once again, thank you to everyone for attending and listening in tonight.
Hi, my name is Megan Linton, and I'm part of the Disability Justice Network of Ontario, and I'll be co-facilitating tonight alongside Ahona. I also use she, her pronouns. So just a little bit about the Disability Justice Network of Ontario. It was founded in 2018 and is currently based in Hamilton, Ontario. Hamilton is the city in Ontario with the largest density of disabled people. Throughout 2021, we're hoping to expand to other cities. We want to start this event by first acknowledging that I am situated on the unceded and illegally occupied territories of the Algonquin and Anishinaabe people. I encourage you to consider where you are. DJNO as an organization is based on the occupied territories of the Anishinaabe and Haudenosaunee peoples on land covered by the Dish with One Spoon Wampum Belt Covenant. I want to take a moment to mention and encourage people to support 1492 Land Back Lane, where Six Nations land defenders continue to reclaim their territory for the past year and have, as a result, faced violent state repression in doing so. As well, less than 2 hours east of me, Kanesatake Mohawk are demanding land back and a moratorium on development on their territory. We understand that disability justice means upholding Indigenous sovereignty. And so I would like other settlers to learn more about the nations whose lands you occupy and how to support their ongoing struggles against settler colonialism and white supremacy wherever you are.
With that, as thousands of murdered Indigenous children's bodies continue to be uncovered on residential institution sites throughout the settler colonial state, we must acknowledge the ongoing violence inflicted upon Indigenous peoples in so-called Canada. Eugenics, forced sterilization, and Eurocentric perceptions of normativity continue to harm, traumatize, and kill Indigenous, marginalized, and disabled communities. From the overrepresentation of Indigenous children in violent, state-sanctioned disability programming, to the disproportionate representation of Indigenous children in ableist foster care placements and group homes, it is clear that the pathologization and genocide of these communities continues to fester before us. With this, we must imagine and reimagine a world where Indigenous, Black, marginalized, mad, labeled, and disabled people are free of carceral systems, whether this be prisons, policing, so-called schools, or medical and psychiatric institutions.
We also want to thank some other organizations who are doing amazing work, and we encourage you to follow them on social media and support their fundraisers. Right now, the Toronto Prisoners' Rights Project is continuing to distribute wealth to incarcerated folks, so check out their ongoing fundraiser. And the Criminalization and Punishment Education Project continues to do wonderful work connecting with incarcerated people and demanding freedom from incarceration.
And with that, we'll dive right into introducing our panelists. Our first panelist is Dr. Emile Joseph. Emile Joseph is an associate professor in the School of Social Work at McMaster University. He currently holds a professorship in equity, identity, and transformation with the Faculty of Social Sciences at McMaster University. He draws on perspectives of critical forensic mental health, MAD studies, post-colonial theory, critical race theory, and critical disability studies to analyze the historical production of ideas about difference, normalcy, sexuality, eugenics, race, ability, and mental illness as they cohere, diverge, interdepend, and perform within policy, law, and practice. Emile has presented and advocated across Canada, in the US, and in Europe on issues related to racism, critical mental health, and social justice. Emile has over a decade of experience in the mental health field in areas of assertive community treatment, community-based early intervention, supportive housing, crisis respite, and governance settings. Emile is also the author of Deportation and the Confluence of Violence Within Forensic Mental Health and Immigration Systems, published by Paul Grieve Macmillan, a historiographical post-colonial analysis of the practice of deportation in Canada for those identified as undesirable.
Truly an amazing book. And our other panelist tonight is Cyrus Marcus Ware. Cyrus is an assistant professor at the School of Arts, McMaster University. He is a Vanier scholar, visual artist, activist, curator, and educator. Cyrus uses drawing, installation, and performance to explore social justice frameworks and Black activist culture, and he's widely shown in galleries and festivals across Canada. He is the co-founder of Black Lives Matter Canada and a core team member of Black Lives Matter Toronto, and a part of the Performance Disability Art Collective. Cyrus holds a doctorate from York University in the Faculty of Environmental Studies. His ongoing curatorial work includes That's So Gay at the Gladstone Hotel and Blackness Yes /Walkorama. He is the co-editor of the best-selling Until We Are Free, Reflections on Black Lives Matter in Canada. Also an amazing book.
And with that, before we begin into our moderated discussion, we would like to invite panelists to self-introduce if so desired, and tell us a bit more about why they're here with us tonight. And before we begin with that, we would like to remind panelists to also speak slowly in order to allow time for our interpreters. And so I will start with Cyrus.
Hello, everyone. My name is Cyrus Marcus Ware. I use he, him pronouns. It is so great to be here tonight. I'm an artist, I'm an activist, I'm a scholar, and I'm a mad person. I first entered into the psychiatric industry 24 years ago, and I'm still involved in this situation. And as a mad person, I've been fighting for justice for mad people for 24 years, really coming in to an understanding of what it would mean to create mad-led community supports that centered mad people. You know, I'm somebody who has experienced psychiatric detention numerous times in my life and have had terrible encounters with policing as a result of madness as well. And so I know from a very personal, from a personal experience, why these systems are not working, what they're actually doing. I have done firsthand research, but I also know from work in the Black Lives Matter movement, we're working in support of the majority of people who are being killed, are being killed during these so-called wellness checks. They're mad people. So, I also know from my work as an activist just how terribly wrong this system is creating these conditions that are resulting in the reality that mad people don't have, access to dignity and justice and life. And so I'm here on this panel because I think that it's important for mad people to be able to talk out about, what the harms of psychiatric detention are, and to dream together into an abolitionist world and imagine what a mad-led world would look like, where we embraced and celebrated all of the ways that our body minds work. I would love to live in that world, and I'd love to dream into that with you. So that's also why I'm here. Thank you. Oh, and for an image description, I'm a Black trans man. I have striped glasses, a polka dot shirt, and long blonde dreadlocks. I'm sitting in front of a white wall.
Hey everyone, I'm Emil Joseph. I'm like as was introduced, I'm an associate professor in the School of Social Work, having a master. I think there's a confluence of trajectories that lead me here, and all of them are equally important. And I won't get into all of them in too much details because we've got a lot to do. I'll say, I refer to my personal context as a Canadian-born Guyanese of South Asian descent, a descendant of Dalit or untouchable indentured laborers who brought to Guyana to toil in sugarcane fields via colonial rule, as a context that brought me to my appreciations of broader context of oppression and my early introductions to substance use and mental health. In my own practice, my first encounter professionally working in the mental health field was with, it used to be called Waterloo Regional Homes for Mental Health. Now it's called Threshold. But they were a community-based mental health organization that provided permanent, affordable, stable housing for people that needed it, for people with mental health histories. And it existed as an alternative to biomedical psychiatry. That was its design, that was its purpose. Throughout my career, I ended up seeing more coercive ends of the system. We thought of it as, progression, advancement in your career. But I ended up in things like early intervention, which is around youth, and then forensic assertive community treatment, which is basically like a hospital on wheels. But we also felt like cops on wheels. And that is where I felt I needed to kind of pull back and do more. And that brought me back to studying the ways in which the context of separation and discrimination, things like colonial contexts, the context of eugenics, the practice of discrimination finds its way into policy and practice and law, especially in relation to mental health. When I worked with ACT, sort of community treatment, I ended up working with those who were struggling with criminal justice issues, trauma, substance, and immigration. And there seemed to be a well-supported scaffold of surveillance legislation to control 4 types of people rather than support them. And I've been working ever since to eradicate some of those things.
Thank you so much. Our first question for tonight kind of emerged because there was lots of questions about the name of our event. And I think that there's lots of curiosity about what abolishing psychiatry and psychiatric incarceration looks like. So we're going to start with the basics and ask, why abolish psychiatry and psychiatric incarceration?
Want to go first, Cyrus?
Go for it. I'll jump in.
I think, I've learned a lot from critical perspectives of mental health and MAD studies and critical disability studies via people who have talked about the kinds of critiques that have existed for, I'm going to say, several decades, maybe a generation, maybe 2, that helped us appreciate that psychiatric interventions had a really long history of using a particular kind of ontology or an explanation, or biomedical explanations and treatments in order to intervene on certain kinds of things. And throughout history, we didn't always name that project, that psychiatry was being something, was something being wielded to intervene on class or race or gender or sexuality or ability, to control for sometimes particular types of behavior, which changed depending on the social or political context, or to control for crime or addiction. I mentioned sexuality, but also to advance a particular kind of project. So conquest, colonization, the appropriation of indigenous lands. We also have a lot of examples where psychiatry was directly connected to the rationale for slavery. We have figures like Samuel Cartwright, who made up diagnoses like tripedomania, dysesthesia, Ethiopus, these rationales that attached pathology to Black slaves who were running away, and made these constructs to control particular types of people, or carry on or advance a particular project, or rationalize something for someone's gain or benefit. I think critical perspectives in disability studies, MAD studies, helped us appreciate how that analysis could be said. And it could be said and known via the lived experience of people who are writing their experiences of oppression, their experience of marginalization, their experiences of containment and confinement. Otherwise, it was obscured from us. In my own history in mental health work, there was limits to what you could see and what you could talk about. And the arguments were, well, that's personal health information, or it's private, and therefore no one can see inside the asylum. No one can speak through it or of it. And MAD studies and critical disability studies gave you a way to say those things out loud. And what they told us was, there is a trajectory of history that took this particular profession and exalted them as expert, embedded them in policy, in law, through what we would argue are fairly drastic accidents in history. Not because they were the best or they had a great explanation, but because they were aligned with particular projects of domination and segregation and removal that were necessary. And what they rationalize, for the most part, isn't care. What they allow for is for containment, removal, and explanations that reduce people in ways that don't allow us to understand people better. But it actually removes a capacity for understanding, to separate us into dehumanized categories in order to rationalize the ways we authorize violence. And that's why it needs to go.
I will, I was just looking at the chat and this question about defining MAD. So just to say, I will often talk about MAD and madness, and just to preface and say that this is a term that we've reclaimed, that we're in the process of reclaiming as we see the development of things like MAD studies and MAD arts and mad activism. Mad activism not new, of course, but this way of reclaiming a term that was used, as a stigmatized term towards people who had been labeled with mental health diagnoses, being reclaimed as a political act, as a way of identifying with the community, and with a political trajectory. So I think that why we need to think about abolish in this context is because we first need to get rid of this fictitious binary that we've created, that there is such a thing as mental health and mental illness. There are all of these different states of being that human minds exhibit, and that there are these different manifestations, and in different cultural contexts, those different states of beings would be considered a lot of different things, and not always pathologized things, sometimes celebrated things. So we've created the context under sort of a Western Eurocentric colonial methodology that has pathologized particular ways that minds work and has celebrated others. So we've created this fictitious binary of mental health and mental illness. And so in order to diagnose what is mental illness, we create a book. That book gets updated and things get taken in and put out. And, homosexuality was in that book, gender identity disorder is still in that book, being trans, AKA being trans, or AKA just being alive is in that book, so there are a lot of things that are in that book that you could really start to ask yourself questions about why those things are being pathologized. And if you ask questions about those, why not ask questions about all of the things that are in that book? Why are we creating this fictitious dichotomy of mental health and mental illness? This creates and sort of predicates psychiatry, and particularly psychiatric detention, is predicated on a fear of madness, on a very fear and a fear, a particular fear of anything that is non-heteronormative white settler sort of behavior gets pathologized and feared. So anyone who is mad, being mad in public space, behaving in unexpected ways, which is what is always said of us, immediately has the police called on them. And the solution to the problem, which isn't a problem, is to disappear the person from the community. So this fear of madness often leads to terrible things. The fear of madness is part of what drives folks to call the cops on mad people being mad in public space, is part of what is, driving this sort of white supremacist and sanist slew of killings by the police of mad people that we've seen in recent years, where, in the case of Andrew Loku, they killed him within 12 seconds of arriving at his house. Just being a mad person, being mad in public space, targets you for death and or for indefinite confinement. And I think that if we're moving towards a kind of society that is more just, that is more rooted in this idea that we take care of each other, which we said in the pandemic, and people clapped and rang bells at 7:30 and said that we were going to commit to taking care of each other. Well, if that's true, then, how are we okay with marking particular people for death and or for indefinite confinement? I think that mad people need justice. We need support. We need access to programs and services, and we need access sometimes to medical supports in the same way that, I also need medical support for having lupus, or for whatever, that there are things that we need support with. What we don't need is this sort of stigmatization, pathologization, and outright fear that is created through things like the DSM and this enforced dichotomy of so-called mental health and mental illness. So, when we look at the reality of, mad people spending significant portions of their lives in indeterminate detention, I know when I was in psychiatric detention in the 90s, I can remember one of the threats that was repeatedly made was, if you keep doing this, or if this doesn't get better, we're going to send you to the really bad hospital, which they meant, and by that they meant the long-term stay, you know, where you would be there and where everybody knew once you got put in there, you were just going to be left there. I mean, this is not a world that I think we're trying to build here for our communities and for our children and for our futures. We're trying to build a different kind of social world. So if you're somebody who can understand the need for access programs, the need for ramps, the need for you know, for changes around disability justice in the world, you know, mad justice is really shouldn't be too far a leap. I mean, I think that when we look at what we're asking for mad people, I think that you know, these are very simple things that we're saying. You know, the right to be able to be, the right for my mind to just be respected and loved for how it is. It's something that I think we're all asking for. So the time is now to talk about what abolition looks like. And I think abolish isn't only tear down and dismantle. Abolish is build up and create. Abolish is necessarily also a process of planting seeds and building something new. So the mad people need things. We have needs, and those needs need to be met. And I think that we can come up with solutions together, like Emile was describing about that, you know, an alternative to a psychiatric model. You know, there are these things that we can create together, that we can co-create together, that offer alternatives. So
Thank you so much to both Cyrus and Emile for setting such a wonderful foundation for our discussion tonight and for sharing your knowledge with us about the importance of fully abolishing psychiatry and psychiatric incarceration. To kind of dive deeper into what you both have shared about abolition, so-called mental health, confinement, and violent intervention within psychiatry, and in regards to kind of in regards to mad people, discourse regarding um, discourse regarding kind of defunding and abolishing police and prisons often focus on so-called mental health care systems as an alternative to policing. But what we often fail to discuss is that psychiatric institutions and systems are foundationally ableist and capitalistic and carceral. So in knowing that calls to defund and abolish police often call for diversions to support so-called mental health care, I would like to ask panelists, why do you think that is? And what is the alternative to diverting funds to so-called mental health care, when in reality, this really means psychiatric care, so-called care?
Mm.
I think I'll just be very brief and say that, you know, one of the first things I think about this is that, you know, we need MAD-led community-based support. So working with MAD people while we're well to create plans for what to do when we're not, in order to prevent fatalities and indefinite incarceration. So alternatives include actually working with MAD people to develop in, you know, community and in family based supports, you know, who to call in a crisis instead of 911 and, you know, things like that. And I think that the other thing is that we need to make sure that the alternative, like the reason why there's so many calls for diversion to mental health supports away from policing is because when police arrive on a psychiatric call, they shoot first and ask questions later. They are literally slaughtering mad people. You know, like there are so many. There are so many that literally I could spend the whole rest of the panel listing the names of the mad people that they've killed. So there's an urgent call for diversion from policing, but we don't want the only other alternative for mad people to be either be killed by the police or be taken away in the psychiatric wagon and locked up indefinitely in a psychiatric detention. So mad people deserve more than those two options. We deserve life, and we deserve to be involved in our care plans and what that looks like when we're not well. Thanks.
Yeah, I would agree with everything Cyrus was talking about. I think the parallels aren't a leap to draw because of the, you know, the similar ways we talk about the genealogies of psychiatry and the asylum and the practice of incarceration. The Mental Health Act, does the work of using a label to rip rights away from someone, to authorize the removal of rights, rather than to afford care or offer care. And people have been saying for decades that it doesn't matter how you conceptualize me is different. What matters is, how you listen to me, and what that looks like in terms of care. And for generations, people have said things like, we need housing that is permanent, affordable, stable, incomes, ways to socialize, ways to connect to others, pathways to education and healthcare that aren't also pathways to incarceration or removal, or pathways to death. We don't want to be identified in schools by systems that are only going to see us in terms of deficit and threat and lack. They're going to try and push us out through those definitions that restrict people's abilities to access the lines of social mobility in life. I think when we look at the genealogies of these trajectories of where psychiatry and psychiatric institutions rose to dominance, you appreciate the illogical pathway that resulted in where we are now. An example would be, 5,000 years ago, there are skulls that are pieces of evidence that have holes in them, trephination, right? Where they used to drill holes to, bleed or let spirits out. It was a way that we can identify that people struggled many thousands of years ago, and people understood, struggle and suffering and distress in multiple ways. They had spiritual ways of understanding, religious ways of understanding, some of them related to biology, and that shifted and merged over time. But it also included an explanation that all of us were capable of all of these emotions and distress feelings and aspects of suffering. What shifted was, through the rise of European colonization and industrialization, was this need to contain and confine those who wouldn't be able to labor in the ways that they thought people would be able to labor. And the rise of the asylum and the institution and the alienist, which is the old word for psychiatrist, arose in that moment, which is peculiar, right? This is where we're talking about the 1600s, 1700s. Just poof, this thing is necessary, right? And why? Well, it served a political purpose. It served a social purpose. And it authorized a way to forcibly sedate, confine, remove people who were identified as other, rather than care for them. And that is a kind of trajectory in our history that we have to lay eyes on for what it is, and what it restricted, and what it doesn't allow for. And what it stands in the way of is our attention to how we care for people by thinking about housing and income and friends and support and education and healthcare and the things that actually make people well, rather than, the systems that we have designed, which are about surveillance and enforcement and incarceration and containment and removal or identification as risk. All of those things that we see resulting in death and harm. So that's how I would connect the two. In that the critiques are the same, actually, if you kind of dig to them.
Yeah, I think, thank you both so much for your answers and responses. I think such a good example of like the violence of the psychiatric system has been the Child Psychiatric Research Institute is currently experiencing a class action lawsuit. And most of the claims they can't actually charge people for because they are legal under our Mental Health Act and in response to behavioral intervention. So we can see how the Mental Health Act works to protect violence and uphold it. So our next question is, psychiatric institutions rely on systems of policing and surveillance against disabled, mad, and labeled people. Can you tell us a bit about the realities of psychiatric incarceration and psychiatry in so-called Canada? So often I think there's a mythology around this, and what you were touching on earlier, Emil, about the nothing can go through the asylum. I think that really sets the tone for this.
I'll start briefly and then Cyrus can jump in. I was, when I found myself in a system where I was a care provider or service provider, or on that end of it, whereas earlier my first encounters were as service user, recipient, or surveilled. The way it was presented to me was that these things are necessary to deal with, the most extreme X or the most extreme crisis, or that which cannot be handled by other means. And what I saw and heard and witnessed was, everything that I was just talking about, ways that we professionally authorized and legitimated ways to use restraints or to force medication on someone without their consent, to take away their rights, to make it so someone else was able to make decisions for them, ways that were just about containment and not about care. That's the kind of thing that we witnessed, when we would go visit people who were picked up and taken to hospital in crisis, if they made it that far. The first time I was in, I will say the Center for Addiction and Mental Health, the secure ward, it was 335. I remember going through 2 secure doors, seeing security, in 2 plates of plexiglass, watching everybody else in a room with all the furniture nailed to the ground and nothing loose. And thinking to myself, how could anyone get better in there? How could that be to them or anyone else care? How could someone experience crisis, be placed in a glass cage with no access to freedom, being treated as not human at all, as only threat, and be well? And it was startling, but the only way I had access to that place was because I was a social worker that worked with West Metro Act, right? Otherwise, you don't get to see that. Like straight up Hannibal Lectership.
Yeah, there's so much neglect and there's so much violence that happens on these wards. I've been on lock wards, and I there's just so much. Your personhood is, it's sort of stripped, immediately in that environment. Any sense of sort of autonomy or selfhood, because you're constantly checked up on. I can remember at one point I was forbidden. You can be forbidden for things like you're not allowed to wear your own clothes, because they want to be able to identify you if you were to run away. you know, if you'd be in your hospital pajamas. So there was like the privilege of being able to wear your own clothes, and when you, you know, would get to that, just all of these ways of really, you know, punitive, really carceral ways of that again weren't about making people feel better, but were about control, you know, and about, you know, probably some sort of medical legal situation, you know, that was more about protecting them, not about protecting us as the, you know, the folks who are in there. You know, and then there was just, you know, ways that violence was also rampant despite the heavy surveillance and these sort of heavy, the heavy presence of sort of the company kind of always watching. You know, there was tremendous amounts of violence. I can remember being on a ward at one point where another patient, you know, there was a terrible incident with another patient, and I was, you know, I ran to the nurse's desk and was like, "Oh my God, this thing just happened," and they just sort of were like, "Well, what do you think happens here?" That was their response. You know, it was just sort of so tolerated that there was a level of violence all the time. You know, that the police presence, that the security guard presence, all of that wasn't mitigating. You know, yet so it was just that, you know, these were not. If anyone has the idea that, you know, you, and this is not even talking about the fact that half of the wards in Toronto are full of bed bugs, that, like, you know, there's like really deplorable conditions in a lot of these situations. Just you know, that if people still are under the idea that you're going to this environment in order to seek some sort of peace, calm, wellness, that's not what we're seeing. That's not what we're talking about, and that's not, you know, the general experience. You know, in relation to, even in relation to the situation, you know, where somebody is really saying, hey, I actually need peace, calm, wellness. Is this a place where I can get it? You know, there isn't even space for people. Anyway, the system is not really a system that is working on making sure that the people who are in it are cared for. The system is working on making sure that madness is controlled. And that is what the wards are functions. That is why they are set up the way that they're set up with the, you know, if you go to prisons and you see how they have the station in the middle and the rooms around the outside and the sort of panopticon, and you go to the mood disorder ward at UBC General or wherever, with the station in the middle and it's, you know, the architecture is it's set up in a particular way.
Yeah, thank you again to panelists for this amazing, amazing discourse. To continue on the topics of kind of surveillance and power within psychiatric institutions, you know, we've seen time and time again that the so-called Canadian mental health care system has repeatedly enforced the incarceration of Black, Indigenous, MAD labeled, and disabled peoples, while psychiatrists, hospital security, so-called healthcare workers, and even police surveil and intimidate these people through violence and involuntary isolation. And so with this, we know that people who work within these institutions have an immense amount of power. And specifically, when I think back to, you know, when I was hospitalized within a psychiatric institution a few months back, hospital workers were, you know, they were extremely unequipped and even vindictive in the way that they intervened in mental health crises, and even in the way that they deprived disabled and mad people of, you know, autonomy and even humane treatment. So with that, the question that I'd like to ask is, what do you, the panelists, want people who work within these institutions to know about psych wards, about their role and about their power?
Want to go first, Cyrus?
Sure. I mean, first of all, I want them to know that madness isn't something that needs to be fixed, managed, or cured necessarily. But to start from that assumption that maybe your first interaction with this person doesn't have to start from a place of fixed manager care. You know, that potentially there is another option where you could kind of meet us where we're at. I think we need to really think about the ways that you can bring in abolitionist practices into your work. So thinking about how in ways that you have any type of decision making in the control of the environment, in the control of policy, in the control of protocols and procedures, thinking through non-carceral ways of interacting with uh, patients, with mad people who are in your care, and really trying to think through non-punitive ways of responding to crisis, responding to conflict when it happens, and responding to harm when it happens. You know, I think these institutions are places where we go when things are often at their most complex. And what we really need is support. What we really need is uh, to have self-direction and autonomy, and to be listened to and to be cared for from a self-directed place. And, you know, if you come in with this sort of police swagger, you know, it really creates a dynamic that is not allowing for any type of informed consent. So, you know, we really need folks who are working in these institutions to critically think about these interactions that they're having, and how they're involved in creating dynamics on the wards or in private practice or in whatever, you know, that sets up the pathologization of mad people, and the sort of taking away of autonomy from ourselves. I have gotten well in psychiatric institutions. I have gotten worse and more ill in psychiatric institutions. I have seen the best and the worst of what there is from coast to coast, because I've been in hospitals from coast to coast, and I have seen it all. And I will honestly say, you know, yes, there are going to be times when I know in my lifetime I may find myself again in one of these institutions, and I know that I'm advocating now for all mad people to be able to self-direct what our care looks like. And if you have any opportunity to be involved in shaping that kind of dynamic in your institution, it will dramatically change the life of the people that you're working with. Because I mean, even when I've been at my worst, you know, what it feels like to have that control of your life taken away through carceral punishment is, it is just, that is not about getting better. That is not about supporting people. So we can take care of each other much better than we do. And I know we can do it.
Yeah, I entirely agree. Um, you know, there's this concept that people use in professionalized clinical spaces, which is the concept of insight, and that, you know, people may lack insight, so being aware of their own condition. And, you know, that construct of insight is, you know, a real keystone to the gap that allows for the erasure of autonomy, that allows for you to suspend this idea that people know what they need, and they know the context of their suffering better than you do via some profession or via some book. Uh, and that you know them as threat and risk, and how to assess threat and risk by, you know, not knowing a person, but just knowing the category that they're stamped with. I think we can help practitioners question those kinds of things, that help them recognize their role as overseers in a system that is designed for surveillance and control and containment, rather than something that has been designed to care for people. I think it is psychiatry and carceral psychiatry in this moment is what exists because we don't care. It is what exists instead of what could be. We could have more supports in community that attend to crises in ways that are compassionate, that look upstream to social determinants of health and well-being, that think about care in ways that don't only look at it in the form of crisis, in emergency rooms, when somebody calls 911, when somebody's suicidal. I think right now people are like, well, there's no other choice. Well, there is lots of other choices. We have for years examples of non-carceral, non-psychiatric interventions in the worst kinds of crisis that existed in community for decades. We had Soteria House, which was designed particularly to be an alternative. I worked in one myself, where we almost never called emergency or police, and even if we needed emergency care, we were trained on how to make sure police weren't the ones we were talking to or about, or who we wanted to respond. We might need some assistance, escorting someone to seek emergency assistance, and this is what we would like it to look like. And this is how they have identified for themselves how care should be carried out. This is what's helpful to them. This is what's been helpful to them in the past. And putting people in the center of what care looks like. We can do all those things. We know they work. We just don't fund those things. Where the money goes is to the hospitals, to the emerge, to the psychiatry, to the police, instead of housing, healthcare, income, education, or people still have to pay for private therapists. There's no way for one to experience the access to counseling or the equity that might result from that because they have to pay for it. And those who don't have the funds to do so aren't covered in any kind of way. Not that counseling is like the solution to these things, but it's part of the puzzle that people should have access to, and free access to that as well. So, in the comments I've seen in passing, I haven't scrolled back through them, but some of that, the representation of, but we don't have anything else. And what I'm telling you is we have lots of everything else in terms of knowledge. If we listen to the lived experience and knowledge of those who have been telling us that they need more downstream, that they need more that is attending to needs rather than them as risk or threat or burden or lack. And we could do a lot better to care for people in that way if we listen better.
Yeah, everything that you just everything that you just said, and just to say, for anyone who's, like in Toronto, there's the Gerstein Center. Like, I just can't stress enough what you're saying here. We have it, just don't fund it. We literally, and I think you're making, I think that as a service user, it is outrageous that there are so many things that would directly improve the care of our lives that are out of pocket expenses, that are not covered, because we're literally putting billions of dollars into policing to be first responders to mental health and crisis calls, so, and training them how to do it, even though they don't seem to, Andrew Loco was killed on a training shift where one officer was training the other in how to de-escalate in a psychiatric intervention. So, we're putting all this money into the wrong places when it could be so clearly going to mad people, to be able to actually direct their care. Mm. So thank you so much for saying that.
I think that those answers put us in a really great place to answer the last of our questions, and then we'll go a little bit into the Q&A, which is, first of all, I think that everyone here should just be so grateful. There has been so much amazing knowledge shared and that we are getting access to. So just thank you so much, Anil and Cyrus. You're sharing so much and so many incredibly helpful resources and ideas and dreams. What does disability justice teach us about abolitionist futures for mad people without psychiatric incarceration? And along with those abolitionist futures, I think maybe touching on some of the abolitionist presence that exists now as well would be helpful for folks in the audience.
You know, when I think about disability justice, or it continues to grow in me as I'm able to connect things that are continuously divided analytically for me in the education system and university institutions, and it's happened a lot where I've had to do a lot of the work myself to see the confluence of historical trajectories whereby our struggles have common themes and threads. And I think, organizations like DJNO have been unique in their capacity to not compromise justice or an orientation to justice or the concept of solidarity to attend to one thing over another, to privilege one aspect of justice that ejects or suspends attentions to others. I think we can talk about Palestine and housing and mental health and disability in ways that are more continuous than we realize. When we're thinking about carceral states and rationalization of violence, how that relates to the ways we authorize and rationalize the separation of peoples, how we remove rights or suspend rights for some and not others. These things connect in ways that could be helpful to all of us. We can think about what we mean by, mental illness or a particular diagnosis, and what we mean when we say those things to ourselves, what we've been taught, and what we mean by criminality. What is a criminal? What do we believe them to be? What ontologically do you believe to be true about this person that's different than you? And we've been taught that there might be a type of person that's different, that there's, biological difference or hereditary difference. Our immigration law is written with these eugenic tropes that tell us that, criminality and mental illness and disability are the traits of hereditary defectiveness that were attached to, people coming into the country, immigrants. So xenophobia is tied to eugenics, is tied to the ways we police medical inspection at borders, is tied to our carceral institutions, is tied to our notions of criminality, is tied to ableism and sanism. These are bound together. And I think we can think complexly in ways that allow us to be, more still about the fact that people live that complexity every day, and they can tell you a lot about it through their experience and what they need, and that we don't need these complex analytical trajectories for people like me to explain them back to you. You can do a lot more listening and understand them on the ground and intervene in ways that are not complicit with those technologies and practices and professions and laws.
Yeah, and I think, disability justice is necessarily rooted in futurity. So, when I think about, Patty Byrne and Aurora Morales writing about the tenets of disability justice, they talk about futurity. They talk about how it's necessarily connected to a futurity. So what it sort of imagines and lets us think through in our abolitionist futures is, these ideas of interdependence, a radical interdependence where our care is connected to each other's. This idea um, of sort of nothing about us without us. This idea that we sort of center the folks who are most affected by the issue in the decision making and leadership of the solution finding, or the problem solving of the issue, which we'll be doing in our abolitionist futures. So disability justice is definitely connected to abolition. And when we imagine these abolitionist futures, we're not just imagining, okay, well, we're going to have a world without prisons, without police, without psych wards, without whatever. We're doing the work of saying, yes, we're going to also have this world with, and we make this much longer list of all the things that we're going to be building together. So food security is a huge issue. Economic justice, those issues affect Mad people in such, tremendous ways, things, environmental justice, like all of these different things that we're going to be building up, making sure that there's housing, making sure that people have access to dental care, making sure that people have access to counselors and mental health supports, if that's something that they want to have access to. Making sure that we have all of these things in place are part of building an abolitionist society, and part of building a different kind of world. If we're working together to try to reimagine this world that we're trying to dream into, why don't we imagine the best possible scenario? So it means letting go and getting rid of that which is no longer serving us. The system cannot be reformed. It is working exactly as it was intended to. It was intended to disappear Mad people, erase us, to disappear us into the institution, to kill us, to eradicate to eradicate madness, to medicate away madness, to disappear madness from human existence. It is that is the reality of what we are currently facing. So if we imagine a kind of future world that looks radically different than that, we're imagining a world where madness would just for once get to rest and get to be. Doesn't mean that we don't want to access medical support, doesn't mean that we don't want to make sure that we have care and everything that we need to handle crisis when it comes up. Of course, I want to have all of those things in place, but I want it to be on my terms. I want it to be defined by myself. I want to be able to be mad anytime, any place, and not worry that I'm going to be killed by the police or taken into psychiatric detention, and sort of, my ripped from my life. You're ripped from everything, and then suddenly left to sort of pick up the pieces, plus deal with the trauma of being in that institution. So when we imagine these sort of mad futures, we're imagining worlds where, things are going to look really different. We're going to interact with each other in different ways. We're going to plan our meetings in different ways because we'll imagine lots of different kinds of neurodivergence. And so we're not going to do 8-hour Zoom days. We're going to imagine for the beautiful human diversity of the ways that our brains work. We're going to actually, imagine and welcome those things. So, if madness was something that could be seen as potentially even something to something that could be desirable, disability as desirable, that is something that I think we're dreaming into in this abolitionist future. And what that means in that framing, it allows us to say, if disability is desirable, if mad people get to exist and we want to have mad people in our world, well, then our interactions and everything that we do needs to radically shift. Our framing around our relationship to this industry, the psychiatric industry, needs to shift. Our commitment to believing these diagnoses, which again, homosexuality was one too, our commitment to investing in the system of pathologization and stigmatization of mad people, we can divest from that. We can start to build something so much freer and so much more beautiful. And it will go hand in hand with building up all of these other things, housing and, economic justice support and, healing the planet, and all of these things are connected. These are all part of building justice for living things on this planet. And I know that we are going to get there. I know that we are going to get freer. And I think that part of how we're going to do that is by listening to mad people. I mean, we actually literally need to listen to all of us crazies right now. Now is the time to really lean in and listen to mad people, and to build a future that is rooted in mad justice, because that's core to abolition. That is absolutely core to abolition.
Wow, thank you, thank you, thank you. Thank you guys so, so much for this amazing conversation. I'm so grateful to be here with you guys and learn from you guys. Um, Cyrus, specifically, I really, really love what you said about disability and desirability. Yeah, it was a really, really wonderful discussion. And we're gonna, before we wrap up, continue on into some questions from the Q&A. So the first question we have here is, as we work to abolish psych systems, how can we do that in a way that doesn't only center the way madness and disability is constructed in the North?
Could you just say it one more time?
Absolutely, yes. So as we work to abolish psych systems, how can we do that in a way that doesn't only center the way madness and disability is constructed in the North?
Yeah, I think that so much of this is part of, what I guess I'm trying to get at it when I say that madness is I'm using the term madness, but this experience of neurodiversity, is taken up in such different ways in so many different places. And the ways that it is understood and sort of comprehended and sort of integrated into a system or a society is so different depending on where it is, and particularly depending on that place's particular context of colonization. So I think it's important to think through um, beyond just what's happening in Turtle Island. I mean, there's so many ways that what is happening in psychiatry and on Turtle Island is impacting the global South and is impacting other places, because the DSM, of course, is exported and is used in particular ways and pathologizing particular people in key places. But I think that it's essential that we have to be sort of thinking more broadly. And when we're thinking about mad justice, we have to be thinking as broadly as possible in terms of our framing and our understanding of the beautiful ways that our minds work.
Yeah. Cyrus was talking earlier about, imagining beyond these confines and a future that could be different. And I think via listening, and, some of this is well documented now. Some of it is via mad studies, some of it is via critical disability and abolitionist literature and speeches and struggles. Um, all these things have helped us to appreciate the ways that we can critique what is this for, who is it for, who is it targeted towards, what does it accomplish, what does it rationalize, and how is it scaffolded, supported by policy, practice, and law. And those fields have helped us, and those experiences, those lived experiences, have helped us, enter into those complex conversations in ways that allow us to say no. No, we won't allow for any version of this system to authorize more harmful treatments just because this type of person has been marked as less desirable to you. No, we won't allow you to just change the name of what solitary confinement is so that you can use it on kids, or you can use it today instead of yesterday, even though we've identified it as a form of torture that you've authorized as permissible for people with disabilities or people who are bad. We can say no to, sending police to respond when someone is in crisis in need of aid, because that thing isn't designed to provide any aid. We can say no to those things. We can say no to the idea of confinement as care, of 4-point restraints, of, we've tried all these medications and you didn't get any better, so we're moving to more invasive interventions. That trajectory of care doesn't need to be the only way to intervene. Just because people inside of psychiatric and carceral institutions believe that their explanation has been, taken to its limits, therefore we need to lock somebody up, or they need ECT, or the more coercive ends of the system. We can say we would like a system whereby someone has equitable access to housing, to crisis support, to care, to healthcare, to education, where they're not going to be identified as risk, threat, burden, or lack in ways that follow them around for the rest of their life, in ways where, the Mental Health Act will follow them around and be a threat to them and what they say. We'll have to pull all of those things down. We'll have to pull down the mental health courts. We'll have to pull down the Mental Health Act. We'll have to divest from these carceral institutions, psychiatry itself, and the asylum, the institution, or whatever you want to call it. It's the same thing. And reinvest in people and community. I think we can do those things and refuse. We can do a lot more refusal and demand investment.
Thank you so much. I think we have time for one more question. There have been a lot of questions, and we appreciate all of them. So one of the questions that keeps coming up is about mandatory reporting, specifically about how medical professionals should engage with mandatory reporting to police, and what alternatives to that would look like. This has been brought up by many, many people. So I'm not sure if we'll be to specifically answer, but love your thoughts on mandatory reporting of harmful behavior or dangerous behaviors.
I can start briefly. A lot of that is mythological. Some people allude to the Mental Health Act as this authority that takes police and psychiatry and makes them the only figures able to act there. And if you pull it apart, that's actually not true. It says, it authorizes police or other person in almost every instance, and there's 12, and you can pull them out. And people have responded to people in crisis for decades, generations, lifetimes, even though the Mental Health Act exists, in ways that don't call 911 or report people because they've identified something that might sound like suicidal ideation, or an idea of self-harm, or some aspect of risk, or something that might sound like imminent kind of harm. There's people who don't respond to the idea that there's a liability to being next to someone who is describing suffering. But and people have been doing that for years, and they do it well. They do it in the community. They do it in ways that identify people's needs, that respond to them, and do so in ways that people describe as in clinical speak, de-escalation, but in ways that respond in compassionate ways that provide care, that do a lot of listening up front. So I think there are lots of ways that we can listen better, and these examples already exist. This myth of liability that comes with, oh, we must call the police because somebody said something suicidal or homicidal, threat to self or threat to others, therefore we might get sued if we don't. That's not true. For years we used to work with people to identify what they wanted to happen when they were in crisis and how we would proceed from that plan by listening first. We started the Waterloo Wellington Dufferin crisis respite model, and one of the first houses, it was like they bought a house. It had 6 rooms. People could stay there, up to 30 days if you needed to, and we could extend that. It was on a giant 1-acre property. Staff were there cooking and supporting people. There were no cops. There were no restraints. There's no forced medications. And that thing exists. We just don't tell that story more broadly. And that's the kind of thing that feeds the mythology that we need the police, that we need emergency psychiatry, that we need this locked unit, that we need the 4-point restraint, which is myth.
Yeah, the only other thing everything that you just said, I will say that, I would kind of want to stress that the most useful situations that I've experienced when in a really difficult crisis spot have been ones where I've been trusted and empowered. And building trust and being able to empower the service user goes a lot farther if you haven't just called the police. So, the reality is that, I have a relationship with my care provider where we have an understanding that I will be honest and direct about where I'm at, and she will not, do these particular things. And that is how we are able to trust each other. And we've been able to build that kind of relationship over, a long period of time. I think that, if for folks who are looking to really center the care of someone, say, who might be experiencing suicidality, one of the surest, I think, ways that you can show care is by investing in behaviors that are going to facilitate trust and allow that person to be able to really reach out and get the care that they need by being able to trust in the relationship. Yeah, when, and then there's also just I think that there's also this question that you have to ask yourself: what would you do differently if you knew, or if you thought about it in this way, that every time that you reported, there was the potential that there was going to be a police-related fatality? And if you thought about it that way, it might make you think a little bit differently about using that as your only go-to to solve, as a way of sort of cut. Because of course the reality is that every time they're brought in, the situation escalates and there's the real potential of a fatality. So sort of thinking about that in relation to if this was really about care. I mean, if it's about something else and you're just protecting your sort of medical legal responsibilities, well, we've already discussed why that can, there's sort of we can poke some holes in that there. But I think that if it's about care, there's a real risk with once they're brought in, because they escalate. And I've already listed Andrew Loku several times, but Abdirahman Abdi, Chantal Moore, Aisha Hudson. I mean, the list goes on and on and on of mad people who weren't given the chance to even explain their personhood. They were just killed during the wellness checks. So yeah, we can do better.
I think that we'll start wrapping up. If anyone would like to share maybe like their favorite resource or resource they would recommend, been lots of requests for any and all resources, or if you just have any parting words. This is not the last event in this series, and there will be an event just focusing on building futures. And so for folks who are talking a lot about solutions, I think that that'll be a really special and wonderful event. But yeah, if you have any final words.
I guess I would just say, you know, really what we're talking about tonight shouldn't be as radical as it is. It shouldn't make everybody clutch their pearls. The idea that we're asking for something a little bit closer to justice than what we currently have. I mean, you need only, I mean, this is why psychiatric wards are disappeared, why they're, you know, people don't go. They've created a sane society that makes it that none of, unless you've been in one, you don't know what it, you know, they've created, they're behind a curtain. But if you go to these institutions and you go onto these wards and you see what the conditions actually are like, you know, I think you know, you really, there's some hard questions that we have to ask about whether this is really about care. So anyways, I really do think that, you know, being able to fight for a different kind of response to emotional crisis, being able to create the conditions where mad people get to decide for themselves how they want to be responded to in a crisis and who they want to be called and what their care plan needs to look like. These shouldn't be radical I mean, like life-shattering ideas. This is fundamental human rights that we're talking about. This is justice. This is what liberation means, you know? So if you're looking at abolition, if you've been following along with defund, if you've been thinking through how to support and create an abolitionist society, supporting mad people is, you know, one of the first things to get involved in, because mad people are the people who are repeatedly being affected by these police fatalities and or disappeared into psychiatric institutions, sometimes for life. So we have a lot of work to do. We can do it together, and let's just build a freer world. We are only going to get freer, and I can't wait to get there with you all.
Thank you. You know, I could say to you, read these things, and well, actually, you know what? There is a couple of really important texts that are Canadian that are you know, mad studies books that came out in the last 5 to 10 years. So Mad Matters is one of them, and the other is Madness, Violence, and Power. They do some of the work of talking about what we're talking about and help us appreciate that none of this is new. You know, Jeffrey Reum, who's at York, has also named the fact that, you know, the Mad Studies collective movements emerged out of civil rights movements. So specific kinds of attentions to abolitionist struggles and anti-Blackness. And that there are ways that we can think together in collective ways that imagine different kinds of things. And, you know, we have to give ourselves permission to do that, to not be surprised by these analyses every time we hear them. You know, I was hired at McMaster and asked to teach a mental health course, and I destroyed that course. And I made a different course, and that course is a course in Mad Studies of Critical Disability. And that's what I've been teaching ever since. And I'm not going to teach anything else because I think this is important, you know. And I think we could do more of it together. But thanks, Cyrus. This is, the best panel to be on with someone like you. So, especially in this topic.
So thankful for your work.
And thanks, Megan and Ahona, the interpreters.
Thank you. And thank you, DJ No, always bringing us such great content and programming and radical discussion. So thankful.
Thank you all so much. The next event is happening on July 30th, and it's Abolish long-term care. I'm super excited for this conversation, so you should definitely register and tune in and follow the work that Emil and Cyrus and Ahona are all doing. And have a good rest of your evening.
Good night.
Right.